Thank you for being here, spending your Saturday with us, talking about livers. And thank you, Scott, for organizing this and the great work that the ALF is doing. I've been very, very happy personally to see the ALF get a lot more involved in the community. And hepatitis C these days, the clinical trials and the science behind it is almost kind of done. And we go to a lot of scientific meetings, and the big Hep C researchers get up there and say, oh, the Hep C problem is solved, it's all over. And I couldn't disagree with them more. Yes, it's the problem of developing the treatments has been solved, because as you saw from Dr. Gutierrez's presentation, we have a great number of treatments that are all getting 95% cure rates. But really, for those of us working in the community, the problem has just begun. And now it's all about implementing and getting the people out there that don't know they have hepatitis C into your clinics. And so it's kind of like the implementation part is really the work that's ahead of us. And it's amazing to me that there are people talking about Hep C elimination, which is really kind of cool. Not just in our country, but in the global perspective. Actually, the World Health Organization is now also talking about Hep C elimination. So I was asked to talk about HIV and Hepatitis C co-infection, and I kind of, when I was putting the slides together, I fell into a little bit of a trap, which is, you know, I think of co-infected patients because I see them. I see a lot of patients that have both HIV and Hepatitis C, and that's a very unique clinical situation. We have to worry about their HIV infection, we have to worry about the drug regimens, we have to worry about drug-drug interactions, and I'll get to that in the talk, but as I was kind of driving over here, the real magic when you talk about HIV and Hepatitis C together is what the Hep C community can learn from what the HIV community has struggled through over the last 35 to 40 years. So let me say that again. So HIV community went from HIV being a disease that wasn't even mentioned by the President of the United States for 5 years after it was discovered, to a disease that's now basically something we can treat with a single pill, and all of that happened because of aggressive and passionate community activism and rallying the HIV community to call their legislators and to change laws and to pass legislation like the Ryan-White Care Act and to get HIV medicines developed and available. And the HIV community has come an incredibly long way, and I feel like the Hep C community is a little bit behind in that regard and is just now starting to galvanize with organizations like ALF to kind of rally the troops and call our legislators and get Hep C more on the radar. HIV has been very successful in getting research funding, so there are billions of dollars that have been spent on HIV research, and the Hep C budget is a fraction of that, a tiny fraction of that from the CDC level. So I'm going to talk about patient care and those kind of issues, and I'm going to talk about epidemiology, but again, I want the overarching message to be there's a lot that Hep C can learn from HIV. So those are my disclosures. What we're going to do is go over the epidemiology, and this is, I think epidemiology is important because it tells you kind of what's going on out there in the country and which patients that you interact with are more likely to have hepatitis C. We're going to talk about the natural history because it's a slightly different natural history than you heard for the mono-infected patient when you have both viruses involved. We'll talk about some key clinical pearls. I'll just kind of give you my sense of how I approach a co-infected patient, how I think it's different than a mono-infected patient. And then the main clinical issue these days is drug-drug interactions. And it gets kind of tedious, but I'll just show you at the end kind of my favorite tools and what to use to get around that. All right, so we'll start with the epidemiology. And I'm going to try to leave plenty of time for questions at the end, so I'll hopefully finish by about 11:30. So, all right, I'm going to start with the bullet points, and then I'll show you the actual data behind all of this in the subsequent slides. So the first thing is that Hep C kills more people than HIV. In the United States. This crossover of the two curves happened in about 2007. Why is that happening? Well, it's a good thing that HIV is becoming less lethal, but it's a bad thing that Hep C is becoming more lethal. And like I said, they crossed in 2007. Among patients that have HIV, and even when the HIV is very well controlled, Hep C is still a major killer of HIV patients. So I'll show you a chart there that shows you how important that is. And that's despite all the amazing improvements we've had in HIV medications. Co-infection is actually still fairly common of both viruses, and that's because of common routes of transmission. You can get HIV from injection drugs, you can get Hep C from injection drugs, and so there's an overlap there. And in large studies in North America and Europe, it's about 25% of patients with HIV that also have hepatitis C. For people like me that are infectious disease specialists, it's how I even got into treating Hep C, because when I was training in Seattle, I had patients that had HIV and Hep C, and I gotta say, the GI colleagues, Dr. Gutierrez is an exception, he's a great doctor, but a lot of them just said, no, I don't want to touch those HIV patients. Not just because they thought it was icky or anything, but because it was actually way harder to treat HIV co-infected patients with those older drugs like interferon, telaprevir, boceprevir, that kind of thing. So overall, a quarter of our HIV patients do have Hep C. In San Diego County, it's a little bit less than that. It's more like 10 to 15% actually, and that's because we tend to have more gay men and less IV drug users in our HIV clinics. Sexual transmission of hepatitis C is a very controversial area, and there's not a lot that's known about it. But what is known is that in especially HIV-positive gay men, that sexual transmission of Hep C is occurring, and it's probably occurring quite commonly. And I'll show you that information. So one by one, I'm going to kind of go through those bullet points and show you the data here. This is a study that was published back in 2012, and it kind of shocked people. The HIV has gotten so much attention in the media in terms of this deadly epidemic. And number one, it's not as common as Hep C, and number two, since 2007, it doesn't kill as many people as hepatitis C does. A couple more reasons that I think are behind this is that this hepatitis C mortality rate is a lot of people that have had Hep C for a long, long time and don't know it. So I see lots of patients in my clinic. Dr. Gutierrez alluded to the fact that there's a lot of young people coming in with hepatitis C. We actually, our epidemiology, I won't show you, but the epidemic curve of Hep C, if you were to do it by age here, is a bimodal thing. So there's 20 to 30-year-olds that have Hep C, and then there's baby boomers that have Hep C. So there's almost like two distinct groups. The 20 to 30-year-olds probably have livers that look okay, and it's more of a risk of them transmitting to other people. The baby boomers that have had Hep C for 30 to 40 years are the ones that are making up a lot of this death that we see. And somewhere between 20 and 40, sometimes some studies even say 50,000 people are dying from hepatitis C per year. So among HIV communities, so this hepatitis C really made a big splash in the HIV literature, because when you look at these giant cohorts of HIV patients that have been followed for years, this one is called DAD, a large cohort of 23,000 people, and they kind of just follow these HIV patients and see what they're dying of these days. They're not really dying of AIDS that much anymore because the drugs are really good. The biggest cause of death is liver-related in HIV-infected people, and of the people that are having liver-related death, the vast majority of those, 2/3 of them is because of hepatitis C. So this was a big wake-up call. We're doing great with our HIV, we're controlling the virus, we have really good numbers, people's immune systems are coming back, but they're still dying of liver disease. So this was an unmet need among the HIV community and really got our attention about this. And then I mentioned overall, if you look at North America, about a quarter of our HIV patients also have hepatitis C, but it really is different depending on how they got their HIV. So that's where you get into risk factors for transmission. This is a study from Johns Hopkins University, one of our leading academic centers, and in their HIV clinic, they had about 2,000 patients that they were following. These are all patients with HIV, so it's an HIV clinic. Among their clinic, almost half of their patients overall have hepatitis C. So about 45% overall, that's the blue one there, overall have hepatitis C. But it was totally different depending on how they got their HIV. If they got their HIV from injection drugs, almost all of them had hepatitis C as well. And if they got their HIV from sexual transmission, either through MSM, or men who have sex with men, or through heterosexual sex, it was much, much lower. So what does that tell you? Well, it tells me, one real easy way to think about it, is that HIV is a sexually transmitted disease that sometimes makes its way into people through injection drugs. And Hep C is a blood-borne pathogen that sometimes is sexually transmitted. So it's like HIV prefers to be a sexually transmitted disease, Hep C prefers to be a blood-borne pathogen, and sometimes there's a little crossover between the two of them. But among injection drug users, that's the population that really is most likely to have both viruses. And this is just another large cohort study saying that it really hasn't changed much through time. So this is, in HIV-infected patients, what's the rate of co-infection? Injection drug users have always had the highest rate of co-infection among other people who had HIV. So, sexual transmission of Hep C. I told you it's a very controversial subject. I'm going to show you just a little bit of the studies that have been done that show that it's a real thing. And then really what I'm going to highlight is how much we don't know about this. So, first of all, before I get to this, let's see if I can hide your eyes. Okay, before I get to that one, there have been cohorts for a long, long time that the CDC has cited saying that Hep C is not sexually transmitted. And those were stable cohorts where there was maybe a Hep C positive man and a Hep C negative woman, something called a serodiscordant couple, or a Hep C positive woman and a Hep C negative man. And they followed these people for years and decades, and almost none of them transmitted Hep C to their partners. So the CDC said, it's not really a sexually transmitted disease, we don't have to worry about it. In fact, they didn't even recommend condoms in that situation. They might have said, well, maybe you shouldn't share razors or something like that because there might be blood transmission, but you don't even need to worry about sexual transmission of Hep C. Then, only about 5 to 10 years ago, it was discovered in New York City and in Australia and some cohorts of gay men that there actually was a lot of sexual transmission of hepatitis C, and that was mostly in HIV-positive gay men having anal sex. So it seems like it is sexually transmitted in certain populations, it isn't in others, and so the HIV-positive gay men has been really the focus of where Hep C has been seen. What this data shows you is that it's not just HIV-positive gay men, it's also HIV-negative gay men, and the key factor here is probably the act of anal sex being different than the act of vaginal sex. So what you see here is the incidence rate of hepatitis C infection in a lot of people. This is 5,000 gay men here, and some of them were HIV positive and some of them were HIV negative, and the incidence rate is much, much higher in the HIV positive men than the HIV negative men, but the HIV negative men, it's not zero. So there's still Hep C being transmitted sexually among gay men, whether they're HIV positive or negative. But it's just a whole lot higher when they're HIV positive. There have been some more detailed studies looking at what is the actual risk factor, what's going on, and what they kind of paint a picture of is it's things related to maybe tissue damage. And it gets very detailed when you go to scientific conferences and everybody's talking about anal sex and fisting and toys and methamphetamine sex and drunk sex and all this stuff. But the bottom line is that things that you would think of that would be more likely to have tissue damage, like sex without lube, sex with toys, fisting, sex with multiple partners, sex while you're high, those types of things are all associated with more Hep C transmission. This chart shows you here that having more partners and having being an anal receptive partner gives you the highest risk compared to having less partners here and then not having much anal sex. So it's probably actually a little tiny bit of blood that's really still relating to the transmission. And then what about the HIV side? We know that HIV, we can tell how good people are doing based on their T-cell count. And there is a relationship where among HIV-positive patients, if you have higher CD4 cell counts or higher T-cell counts, you're less likely to transmit. So there is some aspect where the immune system is probably related to transmission as well. Does that make sense? Okay. So it's you can't just say, people, hey doc, in the last 30 seconds of the visit, is Hep C sexually transmitted? I have to go back in the room and sit down again, because it's actually a more detailed conversation. Well, what kind of sex are you having? And who do you have sex with? And what's the environment there? So it actually can be sexually transmitted in certain situations. Okay, so how do these two viruses play together with each other? Well, it's complicated, and I gotta say there's not a ton that's known about it, because there haven't been a ton of studies, but it's kind of all bad, because HIV-infected patients do have an accelerated course of their liver fibrosis. I think Dr. Gutierrez said something like 20 to 30 years is usually how long it takes to really trash the liver in a Hep C infected patient. There have been cases where HIV co-infected patients, that whole process takes 5 years, from the time they're infected with Hep C to the time they need a transplant or have cirrhosis. Now those are outliers, that's not the norm. But what the norm is that HIV co-infected patients probably progress all the way to cirrhosis about 2 to 3 times faster than Hep C mono-infected patients. So co-infected patients have a much higher risk of having complications. And so in a lot of guidelines, and the guidelines are kind of different state by state, a lot of the guidelines say co-infected patients really should go to the front of the list to get their treatment. So there's plenty of other studies showing that there's an increased risk of liver disease, cirrhosis, and liver cancer in co-infected patients. And there's obvious reasons why. When you don't have as much of an immune system, you can't fight off the Hep C as much, and co-infected patients tend to have higher viral loads and maybe some more damage going on in the liver. This is a little bit of a complicated slide, but I'm going to walk you through it. This is a group of investigators that tried to show what the progression is through the stages of fibrosis, and Dr. Gutierrez mentioned the F score. We talked about F0, 1, 2, 3, and 4, and 4 is equal to cirrhosis. And what you're seeing here is sort of what happens in the natural history of somebody's lifespan if they have hepatitis C, going from age 30 all the way to 60. And as you would expect, when people get older, they tend to go through those stages, and they get higher and higher. What they did here is kind of took some real data and then modeled it through some mathematical modeling, and they did it for mono-infected patients in red and then co-infected patients in gray. And what you can see is the co-infected patients actually reach this line, this arbitrary line of like stage 2 to 3, on average almost 10 years before the mono-infected patients. So a much faster progression and much higher risk of eventually reaching cirrhosis. They probably reached cirrhosis a lot earlier than the mono-infected patients. And then if you want to just look at dying, who dies more? Well, co-infected patients die more frequently. This is a very large cohort study of almost 9,000 people in the VA. Co-infected patients just have a much higher risk of dying. That's maybe related to the liver, maybe not. We're discovering that Hep C is much more than just a liver disease. For the longest time, only GI doctors were the ones treating Hep C. And that was partially because we depended so heavily on the liver biopsy. It's partially because interferon was such a toxic therapy that you really had to have experience using it to feel safe using it, and people out there in the general community, infectious disease doctors like me, didn't really want to use it. Really since, after 2014, the entire Hep C treating community has been turned on its head. And Dr. Gutierrez mentioned that primary care folks can treat Hep C. In our clinic at Family Health Centers, we have 5 primary care doctors that are treating along with me, and they're doing great. Their outcomes are actually just as good as mine. So we did a study on that showing that their cure rates are 95% just like mine are. And we don't really need to do biopsies on anybody anymore. We have lots of other tools to be able to assess the liver disease. So we really need to get this out there in terms of who's actually treating the Hep C. Here's another study. I know I'm kind of blinding you with studies here, but another study showing that the more viruses you have, the worse the outcomes are. This is the triple infection here, HIV, Hep C, and Hep B. Those patients have extremely high risk of having liver problems here. This is incidence rates of end-stage liver disease here. And then different eras, like the early antiretroviral treatment era and the modern era, just showing that our antiretroviral treatment is not really helping much. Even though we're treating HIV much better, it's not making much of an impact here. And so the triply infected patient has the highest risk, and then co-infected patients, whether it be Hep B, HIV co-infected, or Hep C, HIV co-infected, both have very, very high risks of problems with their livers over the long term. Now, we talked about fibrosis staging a little bit. This is a cohort of co-infected patients also from Johns Hopkins. And in the older days, it was like we wouldn't worry about you too much until you were getting up to stage 3 and stage 4. And part of that was because we didn't want to put everybody through interferon. So the line that was usually drawn of when you should be getting your Hep C treating is when you get to stage 3. With the drugs being so much safer these days, I personally feel like everybody should be treated. They should be given the opportunity to get a cure, and we shouldn't be playing God and restricting people like that. But this data shows that we should actually be worried about their health. So even all the way down to an F0 or an F1, if you follow people long enough, there's going to be a certain percentage of death that happens. So this is the proportion surviving over time. You take an F2 patient, who's the gray line here, and if you wait 10 years, half of them are going to die. So why are we not jumping up and down about F2 patients? It's just a longer, slower process. I think Hep C's been easy to ignore because it doesn't make people feel really sick, and it just can go on for a long time, and doctors are busy. Dr. Gutierrez asked, why are primary care doctors not caring about these 40 patients that they have? Well, they've got 1,000 other things to do, and they're getting, the whip is cracking on their backs. You got to see more and more patients, 25 patients per day in my institution. And they have a list of all these other things they need to do, and it's like, why would I just do Hep C? It's not going to kill them today, tomorrow, this week, this month, this year. Let's just let it go. You let it go for too long, and we've let it go in our baby boomers for a long time, they're going to be dying from it. So the time is now to really kind of make this a more upfront thing that we're looking for. Okay, one more piece of data just to show that people decompensate from their liver disease if they're co-infected more frequently than if they're mono-infected. So again, the co-infected patient is just a little bit more vulnerable and fragile. Just want to spend one moment talking again about what we've learned from the HIV epidemic that we can translate into the Hep C epidemic. Like I said, for the longest time, Hep C treatment was really in the domain of the GI doctors. And the GI doctors are great doctors. My first job in college actually was with a GI doc. I love them. But they're organ-focused doctors. No offense, Lisa. They specialize in an organ. Right? A cardiologist cares a lot about your heart and maybe not so much about your feet or your eyes or other parts. A nephrologist really cares about your kidneys. Infectious disease doctors deal with infections every single part of the body, and primary care doctors deal with everything that comes in the door. And in the HIV world, there's been billions of dollars of research to say, what is HIV actually doing? Well, we know it harms your immune system, but it also harms your bones. It gives you osteoporosis, osteopenia. We know it harms your brain. Gives you cognitive problems, and older HIV patients now can't remember things. It harms their nerves. People get peripheral neuropathy. It harms their heart, the high risk of heart attacks. And as an infectious disease doctor, you look at this, well, HIV is a virus that goes throughout the body and is in the bloodstream with a viral load in the millions or hundreds of thousands. Hep C is a virus that goes everywhere in the body and is a viral load, usually in the tens of millions or so. Why is Hep C not causing all these same things? And the answer is it is. There just have not been enough studies to show this. And now that the studies are starting to be done, we're finding really striking things. Guess what? Hep C causes osteoporosis as well. Hep C causes cognitive troubles that get better when you cure the Hep C. I was just at the liver meeting in Europe, and Hep C is linked to cardiovascular diseases. Hep C is linked to diabetes. When you cure Hep C, diabetes tends to get better. So it's no surprise to the ID doctors that Hep C is causing trouble all throughout the body. It's not just the liver. And that is a very strong reason why you should treat that patient who has almost no liver disease. Because what if they're tired and they're fatigued and they don't want to work, or they're having cognitive difficulties that nobody's recognized? Because we've said, oh, your liver looks fine, you don't qualify. Well, if you get Hep C treatment, you get Hep C cured, there's a good chance you're going to make that person feel better, make them smarter, maybe reduce the risk of having a heart attack, maybe reduce the risk of having kidney disease. I have patients where they walk in and they have their biggest complaint is like peripheral neuropathy. They just have numbness in their toes, and it's just bugging the hell out of them. And nobody's diagnosed it because it's really hard to diagnose. You can't really put your finger on it. You get them on Hep C treatment and cured, and their peripheral neuropathy goes away. I have patients that walk in at week 4 of treatment when that viral load is usually just on the way down, and they just walk in and say, I feel like a completely different person. Thank you so much. And their liver looked fine, and their liver's probably going to be fine, but you get that Hep C out of their bodies, and they feel like different people. Now, it's not everybody. Some people are tired before, and then they're tired afterwards. So, not saying it's a magical kind of thing, but there's a lot of things outside the liver that we need to think about with hepatitis C, that it may be causing all these little things. The only reason we haven't talked about this so much is because there hasn't been a lot of research into this. It's been all focused just on the liver. Okay. So, and then if you just want to talk finances, I know Dr. Gutierrez touched on this. Price is always a sensitive issue. There have been plenty of studies commissioned by insurance industries saying where is the cost-effectiveness ratio when treating everybody with Hep C therapy would be cost-effective for everyone. That price point is at about $40,000 for a treatment regimen, and we're already below that with the prices that insurance companies are paying. It's not talked about a lot because a lot of these negotiations are in the back smoky rooms and kind of not available on the public, but for example, the VA pays about $17,000 for a full course of treatment, down from an initial price of $80,000 to $90,000. So we are already beyond the point of cost effectiveness. And what about the cost effectiveness of letting these diseases run their course? Well, in co-infected patients here, you can see it costs a lot just to take care of them compared to mono-infected patients. And what I'm not showing you on this is ER visits and then hospital admissions. So, you know, hospital administrators look at this and say, well, maybe we should be treating these patients. If you look at what it costs to do a liver transplant, it's about $500,000. And then afterwards, to take care of a liver transplant patient, about another $100,000 a year while they're alive. If you take a patient who's about to get a liver transplant who has very sick liver, it's about $50,000 to $75,000 a year just to keep them alive with all their hospital admissions. I saw a patient on Friday who'd been in and out of the hospital 7 times since January. He's got decompensated liver disease. He's already spent the price of a full course of Hep C treatment in his hospital admission. So lots of complicated math going on with the economics of this. So to summarize, co-infected patients suffer significantly higher mortality, liver-related mortality, cancer, and decompensation than their mono-infected colleagues. And the mechanism's really unknown, but it might be all this other stuff that's going on that's kind of systemic inflammation. Okay, I'm just going to give you a couple of my key clinical pearls and still hopefully finish in the next 5 minutes and then open it up for questions. So, first of all, who do we test? Well, we've talked about baby boomer testing, and that's really important, I think, because of all the people that are undiagnosed out there. But people who are HIV positive actually need annual testing for hepatitis C. So if you're dealing at all with HIV patients, they should be getting a Hep C test every year. And that's because of the sexual transmission risk that is probably higher over the background. For men who have sex with men, that's really probably the most important risk factor there. What do we do with patients that have been treated and cured? Well, they're always going to have a Hep C antibody, so that Hep C test is going to stay positive forever. We actually have to keep a closer eye on their liver functions or do a viral load every year to see if they've been reinfected. And then what about reinfection? So this is a very sensitive topic as well, and it comes up in the economic discussions. Well, if you treat all these high-risk people, they're just going to get reinfected, and it's been a big waste of money. The highest group in terms of reinfection from this study here that was published at the CROI meeting a couple years ago is actually the co-infected patients, and the rate was 4.78 per 100 person years, which means like 4 to 5% of your treated and cured cohort is going to get reinfected. And it actually was higher in the HIV co-infected population than it was in the injection drug using population. So if you have a number to pull out, how often does reinfection happen? It's somewhere between, I would say, maybe 2 to 10%, depending on the study, of people that get reinfected. It's obviously higher in people that are still exposing themselves to risk. So in the highest risk, like Dr. Gutierrez mentioned, go right back to prison and then shoot drugs again or get tattoos, it can be up to 15% per year that get reinfected. But in my opinion, that's not a reason to not treat somebody. We don't withhold our diabetes medications because you ate a cookie. We don't deny you from having lung cancer treatment because you can't quit smoking. I mean, it's ridiculous that we're just withholding treatments from people because we're just saying, no, you're not a good enough person in my eyes. That's not why I went to medical school, to judge people and to withhold a potentially life-saving treatment for them. So we try very hard to treat everybody, no matter who they are. Just another little aside from a patient of mine. So a lot of doctors, like especially specialists that aren't really in the trenches in the primary care setting where you keep seeing these patients come back and back and back, specialists have a very easy time saying, yeah, you're not going to qualify. I'm going to give you, like Dr. Gutierrez said, 8 weeks to get sober. Well, when they're your patient in a primary care setting, there's no like just go away. They are your patients, and if they're not getting sober, then it's your fault that you're not giving them the access they need to alcohol and drug treatment. So I had a patient who was not a drug user, but a homeless individual, schizophrenic and not on any antipsychotics, and he was kind of pleasantly schizophrenic. Some schizophrenic patients are just aggressive and they scare you and you want to see them with the door open, right? This guy was just pleasant. He's homeless. He smelled bad. He didn't shower. He lived a couple of blocks from our clinic. He still does. And he would always want to talk about the swarm of bees that was swarming around his head, telling him government secrets and stuff. So I was like, okay, we need to talk about your hepatitis C. We'll talk about that later. So I saw him a couple of times, and I was like, his liver looks pretty bad. He's a stage 3. He really should be treated. And after about the 3rd visit, I'm like, why am I not treating him? He's done everything I've asked him to do. He's come to every appointment. He comes a half hour early. I think he understands what's going on. And then I was surprised. I said, okay, we want to work towards your treatment. And he's talking about the bees and stuff, and he says, oh, and what was my fibrosis score? There you go. And I'm like, okay, he's been listening the whole time. Guess what? He got treated and cured and was one of my most adherent patients that I've had. So we need to get over this kind of sense that I went to medical school and I have an MD and I would play God and say, you should be treated and you should not be treated. That's not my job. My job is to take these amazing advances and give them to people that really need it. And in the Hep C community, we're getting more and more towards the patients that are harder to treat. We're getting into the patients that are homeless and injection drug users and have mental illness and this kind of stuff. So we're going to have to deal with this. And if we don't take care of the other issues, and we blame the patients for having these other issues, we're not doing comprehensive patient-centered healthcare. We need to be giving them addiction therapy, giving them Suboxone if they're addicted to heroin, giving them mental health if they need it. So I'll get off my soapbox there. So what do the guidelines say in terms of co-infected patients? So it gets a little complicated with drug-drug interactions, and I'll get to this in just a little sec towards the end here. The Hep C regimen should sort of guide the choice of the HIV regimen. And it's basically a little chess game that you got to get things to fit together correctly, but we almost always can do it. Antiretroviral therapy should be started in most co-infected patients, and my preference is to get their HIV under control first, and then get the Hep C treated afterwards. Some people choose to defer the antiretroviral therapy and wait until the Hep C treatment is completed. I kind of disagree with that, but I guess it is an option just to eliminate those drug-drug interactions. In people that come to the clinic with AIDS, which means T cells that are very low, below 200, you should probably get them on HIV treatment first, and then get their immune system a little stronger before you treat the Hep C. And then we just watch very, very closely, a little more closely than your typical Hep C mono-infected patient, because we're dealing with more drugs and more can go wrong and there can be more toxicity. So the benefits theoretically of treating the HIV first are to really establish a relationship with patients. I think HIV patients are far more adherent than your general Hep C population because their lives have depended on it. And because we have a perfect blood test to tell us if they're adherent or not. We have an HIV viral load that we check on people every 3 months, and we know if you're not taking your medications. So whereas your typical Hep C patient for me is 50, 60 years old, not really engaged in healthcare, maybe hasn't seen the doctor since they saw the pediatrician, you know, untreated diabetes, untreated hypertension, obesity. Can you take a pill a day? Well, yeah, sure, I can take a pill a day. Well, have they been trying to take a pill a day for the last 30, 40 years? No. Whereas HIV patients, their lives have depended on taking a pill a day, so they actually tend to be a little more adherent. So ensuring adequate adherence and follow-up is a little easier in the co-infected population, and then getting their T cells up probably has some benefits. If you really want to avoid treating the HIV first, you could allow for a simplified focus, a 12-week regimen there, less pill burdens, and avoid some of the drug interactions, which I'll get to in just a little bit. So in summary, my clinical considerations, and I think I'm just going to show you one slide on drug interactions to get through that part. Really because of ongoing risk of Hep C, mostly sexually transmitted Hep C, HIV-positive men who have sex with men should really be tested annually for their hepatitis C. Most co-infected patients, you should treat the HIV first, get them established with an HIV provider, and then address the Hep C. And then the drug-drug interactions are really the major issue. So I'll finish with that, and so give us hopefully 10 minutes or so for questions. So I can't keep all this in my head, and I consider myself a pretty smart guy. So there are many, many drug interactions that you would never even anticipate, so I would say look it up. Dr. Gutierrez says look up the regimens. I say, you know, look up the drug interactions, because they're actually really, really hard to keep track of. Your pharmacy can help you with this, or you can just go to this website. My favorite website, and I don't work for them or anything, I'm promoting them, it's this thing from the UK, the University of Liverpool, and it's fantastic. You can type in the hepatitis drugs that you're using on the left-hand side, all the other co-medications, and they have almost everything there. And then it shows you drug interactions in a really, really intuitive way here. So I've typed in a bunch of drugs here just to show you. Here's a bunch of HIV drugs, and then the interactions show up as a yellow, a red, or a green. And here's most of what we deal with in HIV Hep C drug interactions on one single slide here. So what you can tell is that some of the regimens, and sometimes we're actually forced to use these regimens by insurance companies, some of the regimens actually do have significant drug interactions with the HIV drugs. So this is elbasvir, grazopavir, or it's called Zepatir. Really quite a few drug interactions, and for HIV patients that are taking protease inhibitors, it's really not a good idea to use these two together. So we either have to change the HIV regimen, or we have to write a nasty letter to the insurance company and try to get a different one, which Anais knows I'm pretty good at. Other drugs like sofosbuvir, no interactions whatsoever. So they're actually really, they kind of work well with other drugs. And then some of the newer ones here, this is Harvoni, ledipasvir, sofosbuvir, really pretty clear for most of our HIV regimens. And then valpadisvir, sofosbuvir is another one, with the notable exception of this drug, which is called efavirenz, which is in a triplo, which is a very common HIV drug. So you got to still be careful. There's landmines out there that you might step on. So, all right, I'm going to zoom through some of these. When you go to this website, it actually gives you detailed information, not just a red, yellow, green. It tells you exactly what happens. The AUC is decreased by 34%, so you can make an educated guess, talk to your pharmacist about whether that's clinically significant or not. All right, so I'm going to speed through the end here and just get to my summary. Okay, so to summarize, co-infection is common due to the shared modes of transmission, both IV drugs and sexual transmission in certain situations. Co-infected patients have a much faster progression to fibrosis, probably 2 to 3 times what mono-infected patients have. Both these viruses are systemic viruses. We're kidding ourselves to think that Hep C is just a liver disease. It's not. It's just a matter of doing the research to show more and more non-liver effects of Hep C. Like I said, every meeting that we go to, we see more and more of this. Osteoporosis, heart disease, diabetes, all these things are related to Hep C. In most co-infected patients, you should control the HIV first and then get to the Hep C for many reasons. And the main clinical thing that we deal with are drug-drug interactions, and we can get around it almost all the time. So I'll just summarize by saying, in the HIV community, like I said, 30, 35 years of dealing with this epidemic, and we've made dramatic changes, mostly because of advocacy and people really galvanizing as a community, getting together and fighting for their rights, and getting their lawmakers to change things. Hepatitis C, we've done a little bit of that. I actually got to go to Sacramento and fight for our own Medi-Cal guidelines to be lowered and allow more people to be treated, and that was one of the most gratifying things I've ever done in my career, actually, was getting thousands more people in California access to Hep C treatment because of not doctoring, doing something completely different. So I think I'll stop there and take any questions that you might have.